Good morning, friends. Today I will be taking class on conjunctivitis. So, what is what is conjunctivitis? Conjunctivitis is the inflammation of the conjunctiva. It is always associated with conjunctival hyperemia and increased secretions. Secretion may be watery, mucoid, mucopurulent, and the then classification of conjunctivitis. First classification based on onset. Conjunctivitis may be acute, subacute, and chronic. Next classification is based on conjunctival response. There may be follicular response, there may be papillary response, and there may be granulomatous. In follicular conjunctivitis, follicles are present. Follicles are the aggregation of lymphocytes in the adenoid layer of the conjunctiva. It is seen in viral and chlamydial infections, and papillary response is seen in allergic conjunctivitis. There is a presence of papillae. Papillae Papillae is the hyperplasia of the vascular system of the conjunctiva. Then the third classification based on the type of exudate. The type of exudate has the diagnostic value. The serous exudate it is seen in the viral conjunctivitis. Catarrhal or mucoid exudate is seen in allergic conjunctivitis. Mucopurulent, purulent, membranous, and pseudomembranous exudates are seen in bacterial conjunctivitis. Then the etiological classification of the conjunctivitis. It may be infectious and the non-infectious. Infectious conjunctivitis are caused by bacteria, viruses, parasites, and the fungus. And non-infectious conjunctivitis may be allergic, caused by chemical, sometimes it may caused by the toxins. It may be traumatic, and this may be associated with the diseases of the skin and the mucous membrane. Sometimes it may be bacterial, viral, and allergic conjunctivitis are the more common. I will describe all these conjunctivitis one by one. So, first one is the bacterial conjunctivitis. It may be acute and the chronic. Acute catarrhal or mucopurulent, acute purulent, acute membranous, and the acute pseudomembranous. Then chronic may be chronic simple and the chronic angular conjunctivitis. Then the acute mucopurulent conjunctivitis. It is the most common type of bacterial conjunctivitis. It, it is characterized by marked conjunctival hyperemia and mucopurulent discharge from the these are the organisms causing the acute mucopurulent. This is the picture of acute mucopurulent conjunctivitis. In this picture we can see here there is a mild edema, matting of the eyelashes, conjunctival congestion, presence of mucopurulent discharge at the medial canthus and the cul-de-sac, and cornea looks clear. Now clinical features. Symptoms are foreign body sensation, redness, mild photophobia, mucopurulent discharge, stickiness of the eyelid margins, slight blurring of vision due to presence of mucus flakes in front of the cornea and the color halos. Signs are flecks of mucopus, conjunctival congestion, hemosis, fine type of papillae, petechial hemorrhage, cilia with yellow crust, and eyelid may be edematous. Complications are marginal corneal ulcer, superficial keratitis, blepharitis, or dacrocystitis. This condition treated by broad spectrum topical antibiotics such as chloramphenicol or fourth generation fluoroquinolones, irrigation of the conjunctival sac, dark goggles. We can give anti-inflammatory and analgesic drugs, but there is no role of steroids and the there is no role of the bandage. Now, this is the second condition, acute purulent conjunctivitis. We can see here it's a more severe condition as compared to previous one. There is a copious purulent discharge which is present at the cul-de-sac, and discharge may be running out of the eye. There is presence of conjunctival congestion, chemosis, matting of the eyelashes. It is also called hyperacute conjunctivitis or the acute pulmonarium. It is caused by Neisseria gonorrhoeae. Gonococcal infection directly spreads from genital to the eye. Onset is hyperacute within 12 to 24 hours. Patient complaining of pain with purulent discharge which is copious and swelling of the eyelid which is very marked. And signs are tense and swollen eyelids, discharge is thick, purulent, copious, trickling down the cheeks, chemosis, conjunctival congestion, enlarged and tender preauricular lymph nodes. There is also association of the urethritis and the arthritis. Gonococcus can penetrate intact cornea, so it can causes corneal ulcer, iridocyclitis, so it is very dangerous. It is treated by systemic therapy by the third generation cephalosporins or fluoroquinolones or the penicillin injection. Topically, we have to give broad spectrum antibiotics eye drop, irrigation of the cul-de-sac, dark goggles, warm compresses, and treatment of partner is very important. Now, acute membranous conjunctivitis. It is caused by Corynebacterium diphtheria. So we can see here there is a presence of membrane. It is the fibrinous exudate present over the palpebral conjunctiva. When it bleeds on the peeling, it means it is true membrane. It can cause corneal ulcer and the symblepharon. It is treated by the topical penicillin drop, 1 raised to 10,000 unit per ml, anti-diphtheric serum, and broad spectrum. Then pseudomembranous conjunctivitis. We can see here there is a no bleeding on peeling. It means it is pseudomembrane. It is caused by streptococcus, viruses, herpes simplex, some chemicals such as ammonia and the silver nitrate. It is treated as mycopurulent conjunctivitis. Now we are going to next slide. Chronic bacterial conjunctivitis or simple chronic conjunctivitis. Predisposing factors are chronic exposure to dust, smoke, chemical irritants, local cause such as tracheasis, concretions, foreign body, eye strain due to refractive error, psoriasis, alcohol abuse, insomnia, and the metabolic disorders. It is caused by Staphylococcus aureus. This is the most common or symptoms are burning, grittiness, chronic redness, mild mucous discharge, difficulty in keeping the eyes open, and on and off watering. Signs are congestion of posterior conjunctival vessels, mild papillary hypertrophy, sticky look of conjunctival surface, congested lid margin. Treatment of this condition is to eliminate predisposing factors is very important. Then the topical antibiotics for the 2 weeks and astringent drops for the symptomatic relief. Angular bacterial conjunctivitis. It is mild chronic conjunctivitis confined to the conjunctiva and lid margins near the angles. It is caused by Moraxella excentric bacilli and rarely by Staphylococcus. It is spread by nasal cavity to the eyes. by contaminated fingers or the handkerchief. This bacilli produces a proteolytic enzyme which causes maceration of the epithelium, followed by vascular and cellular responses in the form of mild-grade chronic inflammation. Patient has complained of irritation, burning sensation, and feeling of discomfort. History of collection of dirty white foam discharge at the ankles and the redness in the ankles of the arm. Signs are hyperemia of vulvar conjunctiva near the canthi, hyperemia of lead margins near the ankles, excoriation of the skin around the ankles, and foamy mucopurulent discharge at the ankles. If it is not treated, it can cause blepharitis or shallow marginal lateral focal ulceration. Treatment of associated nasal infection and good personal hygiene are very necessary. It is treated by oxytetracycline 1% eye ointment 2 to 3 times in a day for 14 weeks and zinc lotion in daytime and zinc oxide ointment at bedtime inhibits the proteolytic ferment and thus helps in reducing the maceration.